1, 2, 3. 1, 2, 3. Okay, 1 sec. Yeah, I can, yeah. You can hear. Great. Okay, I get started. So thanks, Ray. Thanks. Bye. Yeah, should be. Just make sure this one's on. Good morning, everyone. Welcome on this beautiful winter morning. So today we are going to do some neurology exam, and so learning outcomes are to be able to competently perform a lower limb sensory exam and a lower limb motor exam. Okay, so fairly straightforward. I need a volunteer. Shh. Yeah, exactly. They're morto for you. So I need a volunteer to be examined. Hamid, do you want to be my volunteer? You forced volunteerism. You can bring your coffee with you because we're going to just need to look at your legs, so it won't take too long. And actually, would you mind turning that around, please? Will you help? Yeah, no, so we just wanted so that I'm examining from the right-hand side, if that makes sense. And what I would like to do for this one, because it's neurology and people find it a little bit more challenging, what would be best for this is if I got one of you to come down and examine first. So what I'm looking for is someone who's really not happy with their neurology exam, who thinks that they're not that good at it. So everyone is just super competent and confident. Is that the issue? Joe, I want you to nominate someone. I mean, I don't hate that idea. You don't mind that? Yeah, having haters is a good sign. Look at Taylor Swift. Now tell me who that is. Faisal. Faisal, I hear that you're terrible at neuro exam. That's what Hamid says. Is that correct? Okay, fantastic. Welcome. The great thing about this, Faisal, is there's absolutely no pressure on you because it's better if you make mistakes, okay? Because then we actually get to talk through the common pitfalls of the mistakes that everybody makes, okay? So there's absolutely no pressure whatsoever. Feel free to do crazy stuff, okay? So what we'll start with is a sensory neuro exam. Is that okay? And we'll give you 5 minutes to do that because that's all you'll get in the actual exam. I'm going to let you put this mic on. So you can put that in your pocket and then touch that up there. That should be okay. And you're probably going to need these guys. Yeah. They look familiar?
Yeah, they look familiar.
Good. That's a great way to start. One day I was doing a junior cycle, OSCE, and the poor girl, she kept going like this to do vibration. And then going, it's not working. And she was very confident that it was not working and there couldn't be any other reason why that was a problem. So at least you know what these are and you have a good idea what they do. So that's a great start, okay? So if you want, you and Hamid can talk for a minute there about what you're going to do because I'm just going to do a little bit of intro to this. Is that okay? So you can turn off your mic while you do that. So let's say you are in the OSCE and someone asks you to examine for a lower limb sensory examination, okay? Obviously, we're going to go through what you need to examine in just a second, but what are the most likely diagnoses, if that is what you're asked? Yeah, peripheral neuropathy in a gloving stocking distribution is by far the most common sensory abnormality that we see, okay? And tell me a little bit more about that. So what would be the common causes of that, for example? Diabetes, and then diabetes, and then diabetes, and then diabetes, and then after that, everything else, right? The reason why I'm pointing that out to you is that if someone says to you lower limb neurology exam, you should have a very educated inspection to look for features of diabetes as well, yeah? So you should be thinking about, can I see a Charcot joint there? Can I see any needling on the fingers? Do they have any glucose drinks around them? Is there any evidence of a glucometer? Anything like that. Walking aids, splints in the shoes for foot drop, all that kind of thing. Okay? So, besides diabetes, what else can cause peripheral neuropathy? So DIMES is the mnemonic that's often used, I-M-E-S. Sorry, D-I-M-E, DIME. I don't think there's any S at the end. So what could I be? Inflammation, so what kind of things, Marty? So Guillain-Barré syndrome you could put in there. You could also say it was immune-mediated, and that would be Guillain-Barré as well. And you'd be quite right with that. And if you said that the eye was infectious, post-infectious could be Guillain-Barré, like Campylobacter-related Guillain-Barré syndrome. So the I sometimes stands for a few different things there. So, but inflammatory things. What other inflammatory things do you know besides Guillain-Barré syndrome? Say if I said from a rheumatological point of view, is there anything you know that causes peripheral neuropathy? That's inflammatory. So rheumatoid arthritis can cause it, and to a lesser extent SLE. Then if someone has chronic inflammation in their body, do you know of any proteins that build up? Amyloid, right? So amyloidosis can cause it. And then you could put amyloid under inflammatory or another I, which is infiltrative. Okay? And so you can get infiltrative neuropathy as well. So can you think of anything else that might infiltrate besides amyloid? So sarcoidosis can cause it, absolutely. Any other ones? And is sarcoid inflammatory? It is, so it goes under that heading too. Anything else you can think of that could infiltrate? Okay. Rarely hemochromatosis and Wilson's disease. Not common, but it's ones I suppose to just have at the back of your list. Then the M is metabolic usually. So can you think of anything from that point of view? B12 deficiency, right. Okay, so what kind of profile is that patient? Young or old, for example? Older, right? Okay, because it's usually nutritional related B12 deficiency that you talk about. Now, you could have an immune-mediated B12 deficiency as well, which would be what? Pernicious anemia, right. Okay, good. So if there's anti-intrinsic factor antibodies or something like that. Right. And does anyone know the classic syndrome you get from a neurological point of view with B12 deficiency? So it's subacute combined degeneration of the spinal cord, right? So with that, they'll get peripheral neuropathy, but can anyone tell me any of the other abnormalities? Cognitive impairment is the main other one that you'll be thinking about. And then in MCQs, you'll hear about them having a lemon yellow tinge to their skin, which I have never seen. Have you seen? Yeah, okay. But, you know, some of you, that's the only thing you'll remember from today because it's very low yield and esoteric, which is therefore goes right to the priority list in and finally her medical student's mind. 2 o'clock in the morning, what was it again? So other metabolic things that you can think of? Sorry, I didn't hear that. Beriberi, yeah, Beriberi syndrome, yeah. I have never seen that, so ask me 0 follow-up questions, please. Alcohol, absolutely. So alcohol is directly toxic to neurons, and it can cause a combination neuropathy usually, so both sensory and motor. But can you put it down as one of the causes of peripheral sensory neuropathy? Absolutely. And then there's other ones like calcium disorders, but I'm going to leave those for now because we're going to put those under the E, which is endocrine. And endocrine, obviously, the most common one is diabetes, and that's why it got its own D at the start by itself, but other endocrine abnormalities can you think of that can cause this? So hypo and hyperparathyroidism can cause it. Hypo and hyperthyroidism can cause it. In the same way that both of them can cause muscular disease, both of them can cause neuropathy. These are not common causes of this, right? Like, let's be clear on that. And acromegaly then is the other one to think about. Okay, and then other things you should think about then are toxins. So what other things besides alcohol could potentially be toxic to the nerves? that you could ingest or be exposed to? Lead, yeah, so heavy metals in general are what you're thinking about. Sorry? So alkylating agents in general then as well, so, and vincristine would be a classic example of that. So if you can't remember specifics and you tell me certain chemotherapeutic agents, I would be delighted with you being able to tell me just that much, okay? And then some anti-TB drugs as well. What's the classic one there? So isoniazid can cause it, and rifampicin to a lesser extent, yeah. Okay. You don't need to know an exhaustive list of toxins, right? But if you know one or two, that's a good idea. All right? So those are the things that you should be thinking about. So on examination, the main one that you're going to be thinking about on general inspection is, does this person have any obvious features of diabetes on general inspection? Do they have any obvious features of a chronic inflammatory process on general inspection? Do they have any evidence of a chronic neurological process? Now, I haven't gone into the actual neurological causes of peripheral neuropathy there at all, like, for example, the inherited sensory motor neuropathies. Okay, so like HSMN1 down to, I think it's down as far as 14 now, but I might be wrong on that. There might be more of them. These are the sort of extra neurological causes of peripheral neuropathy that we're talking about, which are the much more common ones. Okay, you will not have a patient with HSMN in this exam because more than likely that's a pediatric population. Usually we don't see them as much here. And it would be just too difficult to put on for the exam, okay? So, with that in mind, thinking about the things that can cause this, Faisal, we're going to let you go ahead and do your examination. Captain, do you mind doing the timing there? So, the instruction that you would be given, Faisal, is, welcome to your OSCE. I hope you're excited.
Yeah, I am.
Yeah, you look really excited. This is a neurological station, and you have 5 minutes to perform a sensory examination of the lower limbs.
Of the lower limbs, okay.
Okay?
All right. So, hi, my name is Faisal. Before that, I'll clear my hand. My name is Faisal. I've been asked to examine your legs. That will include me checking your sensation and maybe using a cotton wool or a needle that I'll be gentle with it, and a tuning fork. Is that fine? Okay, are you in any pain or anything? Okay. So, just bring that with me. So first, at the end of the bed, patient looked comfortable, sitting on 45 degrees. There is no tremors, no fasciculation, no muscle wasting, no any skin abnormalities like rashes or redness.
You're doing too well here, Faisal. You're not following my brief. Keep going.
And then moving to closer inspection, again, there's no any deformities of the leg. I'll move on to examine the soft touch.
Okay.
Okay. So Hamid, I'll use this cotton wool. I'll use it here. Can you sense this? Yes. Okay. I'll be tapping it on your leg and say yes if you feel it. And let me know if they feel the same on both legs. Is that fine? Yeah. Okay. Can you close your eyes? Do they feel the same?
Yes.
Okay.
Yes.
Do they feel the same?
Yeah.
Right. Okay.
Yes.
Okay.
Yes.
All right. Okay. Do they feel the same all the way? Okay. So soft touch was normal on both
So
sides.
what would you like to do next?
I'll do sharp touch.
Okay. This is your chance to get back at him now.
I don't have to open it, right? Or is it's open the other way?
No, you should open it.
I should open it?
We have 1 or 2 spares.
Yeah.
They gave us a budget for 3 in total for the year.
All right. So this is how it feels. Okay. Again, I'll just tap gently. Let me know if it feels sharp or it feels funny or different sensation, then it's felt there. Okay? So close your eyes. Does it feel sharp?
Yeah.
Is it the same both legs?
Yeah. Yeah. Yeah.
Okay.
Yeah. Yeah.
Does it feel sharp? Too sharp, is it?
No.
He's giving me funny facial
Oh,
expression.
really?
Yeah. Yeah.
Sharp?
Yeah.
And obviously, everyone knows you're meant to keep doing it until you draw blood, right?
So that's the sharp touch. Sharp touch was normal throughout the leg.
Okay, so what do you want to do next? And you've got 1.5 minutes left.
1.5 minutes, okay. So I'll just put this in your leg, but I'll let you feel it here. Feel the vibration? Okay. I'll tap it in your leg and let me know if you feel it or not. No, I'll put it in your foot and let me know if you feel the vibration. Okay. All right. Close your eyes. Feel the vibration?
No.
You don't? Okay. Do you feel the vibration?
No.
You feel the okay. Okay. So vibration felt on the median malleolus on the right leg and felt distally on the left foot.
Okay, and you've got 30 seconds left.
Okay, I'll do proprioception. Next. So Hamid, I'll move your toes up and down. So this is down, this is up, and let me know where it's up, where it's down. Close your eyes. Okay.
Down.
Is it? Okay.
Up. Up.
All right.
Down. Up. Down.
Okay. So proprioception was normal on both foot.
Okay, great. So you,
And then I
2 seconds left.
I can offer to do gait.
yeah,
Checking that.
that's fine.
Yeah.
Well done, Faisal. That was- So, do you want to sit down and you grab your notes because I might need you again in a few minutes? Is that okay? And we're going to talk through all of that. So, I think firstly you can see that it is very achievable to do this much of the exam in 5 minutes. So let's talk through all of that. I think the majority of it was done really well, and there's just 1 or 2 things that we can improve on to tweak the performance to just that really high level, okay? So let's talk about inspection first of all. So quite rightly, you said he was lying down 45-degree angle, and you didn't open with a whole load of he's not this and he's not that, and that's good. You want to say what the abnormalities are. And the important things that you mentioned are fasciculations and tremors. Fasciculation, if you saw that, what would that be indicative of usually? A lower motor neuron lesion, right. So if you saw that and we were doing a sensory examination, what are the kind of things you'd be thinking? So you've got someone who probably has a lower motor neuron lesion, but you've been asked to do a sensory exam, so you're fairly sure that they have some sensory abnormality. So what kind of things would you have where you would get both lower motor neuron lesions and sensory abnormalities? So think about where is the highest place in your nervous system that you can get a lower motor neuron lesion? The anterior horn cell downwards, right, okay? So the anterior horn cell is where what happens? The nerves leave the spinal cord, right, don't they? So you've got your motor route and your spinal and your sensory route leaving the spinal cord through the anterior horn cell. And that's where the upper motor neuron meets the lower motor neuron. And then the lower motor neuron and the sensory nerve both leave, and then they go into the nerve root, and then they will go to a plexus, and each of the nerves then form, in the plexus they will form specific nerves that then go down into specific muscles and sensory external or end organs, correct? Yeah? So if you're thinking of someone who has both a lower motor neuron abnormality and a sensory abnormality, it has to come somewhere from there on. So give me some differentials that would explain that. What about spinal trauma? Could that do it? Yeah, wouldn't that be a reasonable thing to say? Yeah. And in that case, when you find this sensory abnormality, would you expect it to be on both sides or one side? If it were on both sides, would you expect it to be symmetrical or asymmetrical? What do you think? There's no guarantee of anything there, because it could be something that cuts right across the spine, okay? Or it might be something where they have sort of an asymmetrical part, so they get some damage. Let's say he has S1 abnormalities and maybe L5 abnormalities too, sensory-wise, okay? And he also has some fasciculations in his feet. So then it might be that throughout L5 on both sides there has been trauma, or there might have been trauma that to the back, to the lower back, and it hits L5 on the right side completely and on the left partially, yeah? So trauma, you don't know, because which part of the spine is going to be involved totally depends on what the injury was. What else could do it then? So you have your thing, vascular, infection, trauma, neoplastic, etc. So if you go down through those, think about what vascular abnormalities could cause this. To have lower motor neuron lesion and sensory loss. So it would have to be some sort of spinal cord infarct probably, wouldn't it? Or hemorrhage or aneurysm or something like that. So it wouldn't be any higher up is what I'm saying, okay? And it depends on which part of the sensory distribution is affected as to whether this was, say like there's an anterior spinal cord syndrome and that will cause just motor abnormalities, right? But if this was more of a central vascular lesion that caused multiple tributaries and multiple vessels within the spine to be hit, that easily could be it. So any sort of, I guess my point is, if you just say spinal cord vascular lesion, that is good enough for us, because it's impossible for you to be any more specific than that without going into the examination in a lot of detail, okay? So other than vascular and trauma, what other things? The eye for infection, what could that be? What infections do you know that could affect the spinal cord, for example? Sorry? Polio can't, absolutely, yeah. Polio is an interesting one, though, because usually it's just the anterior horn cell, isn't it? Which is just the motor nerve. So you would be unlikely to be asked to do a sensory exam there. Now, I have seen patients with polio who have some sensory abnormalities, but they're subtle. So it would be more likely that in that situation, if you saw the fasciculations, that we were asking you to do a motor exam. And they'd have very classic LMN findings. Sorry? Meningitis, you're getting close to it, because meningitis really is just inflammation of the meninges. But if you got inflammation in the spinal cord from infection, what do we usually call that? Myelitis, yeah. And so transverse myelitis is a relatively common infection that occurs, and that could easily give you those kind of findings. Okay? Inflammatory processes, if you have the second eye, MS, absolutely. Couldn't you think about MS at this? What's the only issue around MS? So it's a central nervous system lesion, isn't it? So wouldn't you expect the motor findings then to be more likely to be upper motor neuron lesions, wouldn't you? That's not to say I have seen some patients who have some fasciculation in MS, okay? And I can't explain that to you. I don't know why it happens, but I have seen it. But I think you would be expecting more to see definitely sensory abnormalities, but upper motor neuron findings with them. Guillain-Barré, absolutely, yeah, you could definitely see that. Mainly a motor neuropathy, but again, you've seen some people who have had sensory stuff. I still think that examination would be more likely to be a motor one too, though. So other inflammatory things to think about are things like malignancy that has spread into the spinal cord, okay? So leptomeningeal carcinoma, stuff like that. Spinal TB. I think, isn't that Pott's disease? Or am I just making that up? Yeah. No, it's Pott's disease, good. Still one or two neurotransmitters going off in there. Okay. Other inflammatory things that you can think of? So lymphoma, which can affect the spinal cord as well. And then the M in general, just malignancies in general. So moving on from inflammatory onto M. Malignancy or neoplastic, whichever one you want to use, the M or the N. Paraneoplastic. So tell me what paraneoplastic you know that causes neurological abnormalities. Yeah, so there's a few. So the commonest one that you think about is like ovarian and small cell colon ones, and they tend to cause central nervous system mets, but then they also can cause, like, you get a cerebellar syndrome with ovarian cancer because of, I think it's anti-U antibodies. So probably less likely to see sensory abnormalities with that, but they are important to think about for sure. Okay, so my point is, once you start examining someone, even when you see just one finding, you should try to start putting things together. So here we've got a sensory examination, so we know we're going to find a sensory abnormality, and then we've seen a fasciculation, so therefore we know we're going to see a lower motor neuron lesion as well. So you're trying to put those two things together. Okay? Now, if you missed the fasciculation and you didn't mention any lower motor neuron related diseases that also cause sensory abnormality, would you fail? Absolutely not, because your goal in this was to perform a sensory examination of the lower limbs. So if you missed those additional things, it's not a big deal. If you do see them, say them and think about them and try and rationalize your differential with them. That's what I'm trying to say to you, okay? So other than fasciculations, I think, Faisal, what else did you mention at this stage? Tremor. Tremor, usually we're talking about, from a neurological point of view, cerebellar causes of that. So then we would be talking about someone who could have both sensory abnormalities and cerebellar abnormalities. And then MS is absolutely the first thing you think about, because you're thinking those are two very separate anatomical areas within the brain, aren't they? Okay, so, and within the spinal cord. So they are lesions separated in space. Yeah? Can you think of many lesions where you can get sensory abnormalities and also get cerebellar abnormalities? Like, what other parts of the brain are together where you could cause that? It's very unlikely, isn't it? A posterior stroke is one of the other things that you should need to think about there, like a Pica syndrome. Now, remember, when we were talking about this situation, are we talking about a peripheral neuropathy then? So if it's coming from the brain, if the lesion is in the brain, it's going to be a central neuropathy, okay? But that can still present with sensory abnormalities, correct? Yeah, so what would be the kind of abnormalities you would see then? So still the same things like absent or diminished touch response, but what would be different about it? Would it be in a glove and stocking distribution, for example? No, probably not, right? It would probably be related to the part of the brain where the lesion was, okay? Is it more likely to be unilateral than bilateral in that case then, isn't it? Because you'd be very unlucky to have two MS lesions where you have the exact same part of both this hemisphere and this hemisphere having the sensory part knocked out. Doesn't that make sense? Okay, so if you saw someone who did have a tremor and they also had sensory abnormalities and you were asked to do a sensory exam, you should be thinking MS, and you should be thinking that the sensory abnormalities in this situation will be central sensory abnormalities, so more likely to be unilateral than bilateral. In order to make sense of what I'm talking about here, what I would highly recommend is that you go back and look online at the two tutorials from last year introducing the concepts of the neurological system, okay, where we talk about how to define if something is a central lesion or a peripheral lesion, how to define if it's unilateral or bilateral, and the few things that you need to pick up on, the patterns that you need to pick up to allow you to make sense of the localizing features, okay? So then you talked about neurocutaneous lesions, I think, Faisal. You mentioned about rashes and scars and things like that. So tell me a few of the things that you were specifically looking for there. What was he getting at? So how about, say, neurofibromas? Yeah? Okay. Would that person have a sensory abnormality, someone who has neurofibromatosis? They could, but it wouldn't be a big feature of their disease, right? What else? Tuberous sclerosis, yeah, so looking for what kind of things? Periungual fibromas, and what other things? So there's a whole list of things that you can get in neurofibromatosis and in tuberous sclerosis. If you haven't learned them by now, I would suggest you don't spend much time on them. Ash leaf macules, and café au lait spots, neurofibromas. This is not a common disease to see in an adult population. You may have seen some of it in pediatrics. I don't think we've ever had a patient with something like that on our short cases. Neurofibromatosis type 2, you see much more in this hospital, where they come in and they have bilateral acoustic neuromas and they're on the neurosurgical ward because they have cerebellopontine angle lesions both sides, and this is causing them problems in terms of hearing, in terms of speaking, in terms of facial nerve involvement. So they can have quite significant disease and need to get it resected. So those patients you will see, and we'll talk about how you go about examining that type of patient when we're doing the cranial nerve exam. But for now, it's really just to have some screening things to know about. So café au lait spots, ash leaf macules, shagreen patches, periungual fibromas. Definitely much more likely stuff that you would see in an MCQ than you will in an actual clinic exam because it's not common here. Okay. Levita reticularis is another rash that you should be looking for. We spoke about that before when we were talking about rheumatological exams. So that's a marbling, mottling type, purpley blue colour. Usually is synonymous with a vasculitis underlying, and the commonest one is polyarthritis nodosa, but also happens in SLE. With both of those diseases, why are they important from a neurological point of view? So arteritis is your issue usually. So these patients get profound cerebral arteritis, which then leads to what? Stroke, exactly. So I had a patient once, and she was stroking every few weeks with her SLE. Really difficult to manage, was on the highest doses of the immunosuppressants, had been tried on many different agents, and this was still happening irregularly. So you can imagine massively debilitating illness. So she had multiple neurological findings from having had multiple different strokes over years, and very difficult to manage when the disease is that bad. So something to think about, again, highly unlikely, not a common thing, but just to have on your radar. Other things to think about are scars. Like if you saw a little scar just there on Hamid's ankle, what would you think that might be from? So that's usually a sural nerve biopsy, and that's done usually in motor neuron disease. Now, in a sensory exam, it's not important, okay? And if you had a patient with motor neuron disease, you certainly wouldn't be in an OSCE station being asked to do a sensory exam on them, because they're highly unlikely to have many sensory findings. But it's something else to have on your relevant negative list. Muscle biopsies then are the other thing, and you'd usually see those in the thighs. And obviously other scars that would be relevant is if you saw a craniotomy scar. And if you wanted, you could go and look behind their ears, looking for scars from having a CPM lesion, like an acoustic neuroma, resected. Okay? Those would be the common scars to be thinking about from a neurological point of view. And you mentioned about muscle bulk, didn't you, Faisal? And this is a really important one, because that is probably the most useful thing to you on general inspection to try to determine between a motor neuron lesion which is upper or lower. Okay? So we'll talk about that in more detail when we go on to the motor exam after your break. But muscle bulk, really important. Okay? If there had been anything around the bed, then we'd have talked about that. So splints, walking aids, really important. There wasn't time to do gait in this. If you're asked to do gait in the exam, it'll possibly be just a gait exam. Or you might be asked to just examine the gait and the reflexes or something like that. Okay? Because there's quite a bit to it, and you wouldn't get it done in 5 minutes as well as a sensory exam. So let's move on then, and we need to do what in our sensory exam? What are the purposes in terms of testing tracts? What tracts are we trying to test? Dorsal columns and spinothalamic tract. And the dorsal columns will test vibration and proprioception, and the spinothalamic tract, pain and temperature. Okay, so Faisal, you chose to start with soft touch, and so where is soft touch carried? Both. Okay, so there's some soft touch in both the dorsal columns and in the spinothalamic tract, mainly spinothalamic tract, but there's some in the others. So it is the one that is done first in a diabetic clinic because it's a good screening test to see if there's any abnormality. So you can do it with a piece of cotton wool or you can do it with a microfilament, whichever you have. The difficulty I have with it is the least specific, right? So it's very sensitive, but it's the least specific. So I wouldn't personally start with it because what I'm thinking is I only have 5 minutes to go here. What I want to do is test one modality in the spinal thalamic tracts, one modality in the dorsal columns, so that if I run out of time, at least I have tested both and I'm able to make a comment on whether that tract is intact or not. Does that make sense? That is not a requirement. What you certainly won't be marked down for doing it in any other direction or in any other sequence. That's just my own personal preference in terms of strategizing around the exam so I can present something at the end. So I'm going to start differently, and I am going to start with doing the spinal thalamic tract. And we said that is temperature and pain, or in the exam, instead of saying pain, what will you say? Sharp touch. Yeah, I think that sounds a little bit more palatable to the patient, particularly if they're going to have 20 students do this to them one after the other. So when you are testing for any of the sensory modalities, the things that you need to remember are some basic principles. Number one, most sensory abnormality is not absence of sensation, it is diminished sensation. Okay? So if you only ask the patient, can they feel it or not, most of the time they will still be able to feel it even if they have diminished sensation. Okay? So I could have someone who has quite significant stocking neuropathy in their feet, but if I just say to them, can you feel that? Yes, they can feel it. Whereas if I ask them, does that feel the same as it did on your chest? They will say no. Okay? So can you see if you the way you ask the question is important, or you will underdiagnose a lot of abnormality. The second thing to remember is that we need to test all the dermatomes. That's not to say that we're expecting a dermatomal distribution, it's just the most methodical way to do it. Whether you start at the bottom and move upwards, or at the top and move downwards, does not matter. Okay? This one was a little bit interesting, Basil, because I saw you do here, 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 and then you did here, and then you did here, and then you decided, I'll do here, and now I'll go back here and here. I think maybe you were just getting a little bit of rage out on Hamid, because there was a few of them that you tested twice, and then there was one, the S1, that I wasn't convinced was tested. Okay? So when you're talking about this one, the important thing is to know where the dermatomes are, test each one once, and I often would signpost it to the examiner so they know exactly what I'm doing. The second thing is, it's highly unlikely that if someone has a sensory neuropathy that they will have no feeling this high up. That would be an incredibly high lesion. And if the person had a lesion that was that high, it's highly unlikely they're going to be in your exam, okay, because they're going to have such significant disability. So it's a good idea to use here as your baseline control. So, Hamid, can you feel that? And does it feel sharp or dull? Okay, can you close your eyes for me? And now tell me, is that sharp or dull? No? Okay, so I test with both sides to make sure I know that he knows the difference. Okay, so that's the dull part that is plastic covered, and the sharp part is the part with the needle, right? And I've got him to close his eyes to ensure that he's not just looking at it. Okay? All right, so I'm going to get you to close your eyes again. Okay, can you feel that? Does it feel the same as on your chest? No. Okay. Now? No? You feel it, but it's not the same. Okay? Now? Same as on your chest? Here? Okay. Here? 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 Okay. Here? I'm sorry. Here? Here? Here. All the time the same as on your chest. Okay, so you've got a lesion that's not reported in the literature. Yeah, so I think it was hypertextilemia there was going on, so there was excessive material and you didn't feel it. But because normally if it were abnormal here, you would expect it to be abnormal below that as well, correct? Okay, so few pointers there. Always test at the chest. Get him to close his eyes. Test both sharp and dull there, and tell him then that it's the sharp one that you're looking for. And the question you ask is it the same, as opposed to can you feel it? Okay. I do L1 here, L2 here, L3 over the knee, L4 the inside of the leg, L5 the outside of the leg, and S1 the little toe on the back side of it. There are obviously other places that you can test. That's how I've tested for the last 15, 16 years. So I'm going to continue to do it that way. Okay. RC side doesn't matter. Okay. Once you test each dermatome, okay, it doesn't matter as long as you test each dermatome. All right. Now, let's see if we find them. Now, you're Faisal as well. Tell me what you want to ask me. Why do you think so? Yeah, no, it's because they know then for sure if their eyes are open that you actually have touched them or not. Whereas if they've got their eyes closed, they don't know if you've touched them or not. Okay? Yeah, so if they say no, it might be because you didn't touch them. So that's fine. Okay? Patients often over-report stuff and say that they can feel something when they can't because they think they're meant to. And they don't mean to confuse you or anything, but it's just that they're trying to help out, right? Now, let's talk about the situation where Hamid could not feel, let's say, down here. So what would that be? S1. And he couldn't feel all the way up as far as here. Okay? So what would that be? L4 and 5. But what's our problem with that? Do L4 and 5 just abruptly end there? Okay. So does he have a dermatomal distribution of his loss? No. Okay. Is that possible? Absolutely. So when do you get non-dermatomal distribution of sensory loss? With peripheral neuropathy, which is the one that we are commonly seeing. Okay? So what's nice then for you to demonstrate is that it's non-dermatomal in origin. And how you'll do that is, so I've examined all the way up and down, and everything has been completely normal on this leg. And then once we got as far as here, he said, no, can't feel that, can't feel that, can't feel that. Okay? So now I want to demonstrate to the examiner that I know that this is non-dermatomal in origin. So I get him to keep his eyes closed and say, okay, can you feel that? No. No, Hamid. My gosh. It's okay. Don't worry. Okay. Can you feel that? No. Anything there? 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 Okay. And on this side, here? 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 Okay. So what we're after showing is that we're after going from an area of L5 that is abnormal to an area of L5 that is normal, on the inside, on the outside, and then on an area of L4 that is abnormal to an area of L4 that is normal, i.e. this is non-dermatomal in distribution. Does that make sense? Now, you don't have to add that bit in if you don't want or if you think you've run out of time, but it does look nice and slick to the examiner. It shows that before you've ever presented your findings, you've identified a specific pattern of sensory loss. Okay? Oh, absolutely. So if the loss of sensation was all the way to here and then you were up feeling here, I would start it just about here instead. So I'd be saying, okay, can you feel that? That, and so we'd be seeing from L3 here, you have an area of abnormality of L3 to an area of normality of L3. Does that make sense to you? Yes, what's your name? Eve. So I'm not fully sure I get the question. So you're saying if they've lost from here down? No, up to the knee, so you're not sure. Because I've only examined L1, L2, L3 here is what you're saying. Yeah. So You will have gone down here and you will have felt here and they'll have said no to this, yeah?
So like you've gone down under L3
1, yeah. Sure.
they've lost from L4.
Sure, yeah. So what you need to do, yeah, because then you can find an area where you move from L4 that's normal to L4 that's from abnormal to normal. Yeah. Is that okay? Now, would you expect it to be that he would have only abnormality in this leg and not in that leg, or peripheral neuropathy? It's unusual, isn't it? And usually what you find is that it will be bilateral, okay? Because the main problem in a peripheral neuropathy is that there has been some sort of toxic injury to the nerve. So glycosylation is the reason that it happens when you have diabetic disease. So it shouldn't prioritize one leg over the other. Having said that, you almost never see a patient who has completely symmetrical neuropathy. So they'll have it bilaterally, but like it might go as far as here in this leg and as far as here in this leg, for example, okay? So don't be put off by that. Almost all patients with diabetes will say to you, this is my bad leg, and this one could have 3 ulcers on it, but this one has 4 ulcers and a Charcot joint, right? So bilateral, but not necessarily perfectly symmetrical, okay? So if you're describing it at the end, you would describe it as an ascending sensory polyneuropathy, so ascending, going from there upwards. That is non-dermatomal in distribution. And also looks like it has a stocking distribution. And it's bilateral, but slightly asymmetrical. Okay, so ascending sensory neuropathy, non-dermatomal and stocking in distribution, and bilateral but slightly asymmetrical. And obviously you would say you would like to then assess the arms as well to look for a glove distribution there. Put that back. So, is everyone happy now that firstly we have tested sharp touch, so spinal thalamic tract. So now I want to test the dorsal columns. Okay? So of the dorsal column options, you've got vibration or proprioception. Which do you think is more likely to elicit an abnormality? Which do we see an abnormality in first, usually in patients? Vibration, yeah. So that's what I'm going to choose next. So my sequence of events is always inspection followed by sharp touch, followed by vibration. Okay? And we have a 128 hertz tuning fork here. That's the ideal one. But if you only have a 256, you don't need to go out and buy another one. That'll be fine. It'll still work. It's just not as easy to maneuver for you because it's a little bit shorter. Plus also it's theoretically better for doing your Rinne's and Weber's tests. I am going to get you to hold this for me, Hannah. Is that okay? All right. So we're going to go with the exact same principles. Test up here first. I mean, can you feel that? Sorry, close your eyes. Can you feel that? What does it feel like? Buzz? Okay, tell me when it stops. Okay. The reason why you ask, does it feel like a buzz, is because most people will feel the coldness anyway, and you don't want them to be reporting that. That's what they feel. You want them to be reporting it's the vibration that they feel. Okay? So once again, close your eyes. Can you feel a buzz? Tell me when it stops. Okay. And so where do I start then? Usually at the most distal bony prominence. So usually where would that be? Over the greater hallux, yeah? Okay. Catherine, I need you, sorry. So exact same. Keep your eyes closed there for me, Hannah. So can you feel a buzz? Same as on your chest? Tell me when it stops. Okay. Can you feel a buzz? Same as on your chest? Tell me when it stops. So you've got two screening questions there. So you've got tell me, was it the same as on your chest? And tell me when it stops. So even if they say to you, yeah, it was definitely the same as on my chest, but then they don't know when it stops, that's reported as being abnormal, okay? So if they get either of them wrong, it's abnormal, correct? So Hamid had no abnormality distally for vibration. So do I move any further? No. Okay, but if he had reported either that it didn't feel the same as on his chest or he wasn't able to tell me when it stopped, what would I do next? I would move to the next bony prominence, so over the medial malleolus, and then after that, knee. What about if it's completely normal on this leg and it's not on this? Will I do both medial malleoli? No, you only have to do this one then, okay? Just to save you time. It doesn't make sense. If this is normal, you don't need to go any further on that leg. And if it's abnormal there, you'd move on to the knee, and then you can move on to the hip, but like it's just useless, so there's no point. Just on the bony prominence there, okay? So I would put it just about there, all right? And it's highly unlikely that they will have abnormalities all the way up as far as there from a vibration point of view, okay? Dorsal column is a little bit better preserved than the STT. So then, if I've not run out of time, I am going to do the other tests, okay? And I usually leave soft touch to last because, as I said, it tests both tracks, so it gives me less information, really. So I would do proprioception next. That's just me. Now, there's a few things that you can do wrong here. So you're looking at the big toe, and what you want to do is try and get your fingers on the sides of it as opposed to holding it like that so that they don't feel pressure, because the little hair cells pick up the pressure quite easily and they'll know which way you're moving it then. So you're getting your fingers on each side. How much do you think you should move it? Someone who doesn't like Hamid said 45 degrees. No, so about 5 millimeters is all you should be moving it, okay? In the finger, it's meant to be only 1 millimeter, so really tiny movements. So, Hamid, if you hold that there for me, I can tell you, anyone, even if they have had no sensation for a long period of time, if you do this to them, they'll have a fairly good idea that it's pointing downwards. And if you do that too, that's far too rigorous, okay? So it's only a very small movement that you're talking about. So it's going to be something like this. Okay? So almost invisible to the naked eye. Not quite. But my point is you need to be relatively subtle with that in order for you to be able to pick up the abnormalities, because otherwise no one will ever have an abnormality if you're yanking their toe off them as you do it. Okay? So we'll go through that. Sorry, Catherine. Hamid, this is up and this is down. Can you close your eyes for me? Can you tell me now, is your toe up or down? So tell me, am I moving it more or less than Faisal was? I'm moving it less. Okay. So now you know. So that you did one thing wrong, so at least I was able to teach one thing. Okay? So you coming here today was good for some reason. And again, if it's normal there, you do on the other foot. And where would you move to next? To the ankle. This looks really clunky, and most examiners will say to you, don't bother, okay? You can just report that there is some proprioception abnormality at the toe and that you would like to test further. But just in case someone does ask you, sorry, Catherine, I'm going to need you to do this again. So you're going to hold the foot here, and then you're going to very subtly move like this. So, Hamid, this is up, this is down. Can you close your eyes for me? Is that up or down? Okay. So there's really not a lot to it, and is it very useful? Probably not, okay? But just so you're aware of what to do in that situation, and we don't move up any further, it kind of becomes pointless thereafter, all right? And then finally, I will do soft touch, and I'm not going to spend long on this because it's the exact same as sharp touch. The important thing is that you don't stroke your patient, because again, that will make them feel, the hair follicles will feel that. So it's an up and down movement, not a back and forth movement, okay? So can you close your eyes for me there, Hamid? Okay, can you feel that? Is it soft like cotton wool? Yeah, okay. So keep the eyes closed. Can you feel that? Same as on your chest? Same as on your chest? Same as on your chest? Okay. I hadn't even touched you that time. You were saying it before me, getting bored by me. Okay. And so that's what you're talking about. If you really want to save time even more, I would say start distally and move laterally, because where are the findings more likely to be? Distally, yeah, okay. But I think you will pretty much have enough time to do all of that in the exam, all right? Anyone, any questions on any of those parts? Okay. This is a really common examination for you to have to do. Now, let's say we gave you a slightly different instruction, and we said, this patient has diabetes, demonstrate the abnormal findings in their legs. Okay? So, talk me through what would be different there. So, would they have potentially all those findings that we've just gone through there in relation to peripheral neuropathy? Yeah, absolutely. But what other things might be there too? So there might be vascular abnormalities as well that we need to talk about, correct? So tell me a bit about diabetic feet. What's the pathogenesis? So I've already told you that chronic hyperglycemia causes glycosylation of the nerves, and that's directly toxic to them, and that's what causes most of the peripheral neuropathy element. Okay? But what about the vascular elements? So there's accelerated atherosclerosis, isn't there? Yeah. And so that is going to cause them to have peripheral vascular disease, which can be both arterial and venous, but the arterial stuff is what we're more concerned about in the context of a diabetic foot. Okay? And so that combination of accelerated atherosclerosis leads to poor blood supply, which leads to poor healing, and then glycosylation of the nerves leads to neuropathy, which leads to abnormal sensation. So you have a situation whereby they are prone to having an injury which is undetected, and then having poor blood supply in order to heal that injury, and hyperglycemia, which is going to make them prone to infection. Okay? So you've got a combination of three very significant pathological processes happening. And all of that can lead to ulceration, which can become chronic infection, osteomyelitis, so chronic skin infection, but also bone infection. And then that can lead to breakdown of the bone, and then distorted architecture of the bone as it tries to remodel and regrow, which can lead to what we know as this arthropathy called Charcot's foot, and most commonly seen where? In the feet, but specifically where? At the ankle joint, right? So therefore, in this examination, doesn't it make sense that you will be looking at neurological abnormalities, but also vascular abnormalities? And you would also be quite interested in how they walk, because that might be significantly impaired. For example, they might have a walking aid, they might have a space boot, they might have a splint. Okay. We have one patient, and she comes in for every exam going, so I'm sure lots of you have met her already, and she's had type 2 diabetes for a very long time, and for about 3 years she was in a space boot due to having chronic osteomyelitis and ulceration of one of her Charcot joints. She's now managed to get off of that, which is great. But you're talking about people who have very long-standing severe disease that is really quality of life impairing. So all of those things are really important to point out, because that might be the most significant issue for the patient. They can't walk or mobilize to any great extent. Okay. So let's imagine Hamid has a really distorted looking joint here, and he has multiple ulcers, and he has all of the stigmata on inspection of diabetic disease at its worst. Tell me the things that you will be commenting on. What colour is this leg going to be, for example? Pale, okay? So your leg, rather than being brown, might be more jaundice kind of coloured, Okay? Because what I mean is, like, you know, if you're not someone who's white, it's not going to be white, right? Okay, so pale is the best way to describe it. Okay? What else might you see? Yeah, so will there be much hair on the leg usually? No. Okay, so the hair will be gone. What about the nails? Dystrophic. So all of that, those things can be combined to say there's integumentary changes on the leg. Or you can just name them specifically. That's integumentary. Okay, what else might you see? Ulcers. Tell me what type of ulcers these are going to be. You're going to have to help me here. I don't have to describe ulcers very much anymore. So you guys will definitely be better at this than I am. So are they going to be arterial or venous or mixed? Most likely arterial, but there could be some mixed ones as well. Whereabouts do you get the arterial ones? Pressure points? That sounds right to me. Yeah, okay, so where am I going to be looking for them? Between the toes, down here, the base of the foot. Yeah, if he's in bed all the time, that's where he's going to get them, right? Okay, anywhere else? Up here, just base of the toes. Does that all sound right, or am I just making it all up? That's good? Great. Okay, so what kind of walls do you have on an arterial ulcer? Punched out walls. Okay, so they're quite obvious, aren't they? Are they going to be quite tender when you feel them or not? Yeah, pretty painful, okay? So tender, punched out walls in the areas of the pressure points. You don't need to go into any more detail than that because you only have 5 minutes. If this was, you had walked into the exam and they say, this is a vascular station, examine this patient's ulcers, then you can go to town talking about the base and the granulation tissue and how many millimeters you think the wall is and how many millimeters you think the centre is and whether you can see fascia and all that kind of stuff that surgeons like to talk about. But for our purposes today, that's definitely enough. So where they are, what kind of walls do they have, whether they're painful or non-painful. How do you know whether they're painful or not? I would ask the patient as opposed to, you know, digging your fingers into it. I think that that's probably the more appropriate thing to do. Okay, so ulcers is one thing that you'd be talking about. Hair loss, the colour of the leg, and the nails, all indicative of poor blood supply to the leg. Yeah? Okay? Any scars that might be there that would be interesting to you? Like if they had scars, saphenous vein grafts, and then if you looked under their legs and you saw that they potentially had some scars under their knees and possibly at their hips and stuff. So you'd be thinking about had they had any other vascular surgeries, wouldn't you? So saphenous vein grafts because they had cardiovascular disease. And then bypass surgeries, okay? Is it common that you would have a diabetic who has had bypass surgery? Absolutely. Now, these days, they might have had minimally invasive stuff, so all they might have is a very well-healed angiocyte scar, okay? But it's still good for you to say, and I'm looking for angiocyte scars and scars related to bypass surgery, which would be common in this vascular patient. Yeah? Okay. So then you're going to describe this abnormal looking joint. So you can say that the ankle joint looks abnormal. It looks swollen and there is distorted architecture of the bone, and I'd like to feel that to confirm that it's bony swelling. Okay? But we're still only on inspection at this point. And then inspection around the bed, looking for space boots, splints, walking aids. So then we're going to move on to actual palpation now. So with our palpation, there's only going to be 1 or 2 things we do because we still have to do a full sensory exam, don't we? So that inspection that we're after going through, that's after taking us about 8 minutes, you want to get that down to about 30 seconds, okay? So what things do you think are high yield to do here to show that you can do, to test for vascular integrity? Yeah, so I would do a capillary refill quickly, first of all. So you want to see, is it greater than 2 seconds on both feet? And then you would want to examine for distal pulses, okay? And more than likely, they will just get you to do dorsalis pedis. And so tell me what the landmarks for this are, because I would say every second long case I have done since 2007, the surgical examiner has asked this. This is one of the favourite things to ask, and they get quite upset if people get it wrong. So, come on, help me with this one, guys. What are the landmarks? So you get this medial malleolus and lateral malleolus. What am I going to do with those? Draw a line between them and then get the midpoint of that. Okay, now where am I going to move from here? A line to where? The first interdigital space. Great. Okay, now what do I do with that line? Is it 1/3 or is it 1/2? Who says 1/3? Who says 1/2? Great. Okay. Sorry, I thought I heard someone say 1/2. Yeah. So 1/3, and so this roughly here. Does that look like I'm feeling in the right place? You're dead. Your feet are dead. Don't tell him, guys. We'll do Breaking Bad news later on, okay? No. So you're looking for a pulse here and a pulse here. Should you feel an absent pulse in diabetes? They're quite common. And why do you get that? Because of the atherosclerosis causing lots of calcification of the vessels, okay? Girls, do you have a question for me? Question? No, that's fine. Now, so that's, and then if you were asked to feel any other pulses, what other ones are there? There's one in here, isn't there? You can tell I'm really excited by feeling for pulses. It's what I love to do. What one do you feel for in here? Posterior tibial. So tell me where that one is. Between the medial malleolus and? Yes. So somewhere around here? Great. Yeah. Okay, that one's there anyway, for sure. Okay. And obviously you'd be doing that bilaterally, and then you could move on to the popliteal. Yeah. Anyway, I'm not doing that. I'm just over it. Okay, so you all know how to do that. Everyone is saying all that perfectly. So more than likely you will just do capillary refill and dorsalis pedis, and then you're going to move swiftly on to doing your neurological exam. And in this case, wouldn't it be appropriate to just do one spinal thalamic tract and one dorsal column test, because you've spent probably half of your time doing all that vascular stuff, so now you're going to spend the rest of your time doing the neurological stuff. And because you know which tracks you're testing, you can quite strategically do that. So in my case, what I would pick would be sharp touch and vibration. Those are the two that I would preferentially do. Yes, you've told me your name before and I can't remember, I'm sorry. Lisa. Monofilament is the same as soft touch, effectively. Okay, so the cotton wool and the monofilament are the same. And in the diabetic clinic, they do that because it tests both, so it's a nice screening test. So it's good for sensitivity, not good for specificity. Does that make sense to you? Okay, so functionally, it's the most useful one to do. But if you want to determine which tract is involved, not useful for you. Is that all right, everybody? So take a look at some gruesome looking legs online and make sure that you're able to describe them well from an inspection point of view. And there's a few in your books as well, I think, and work through that. Every second patient who comes into clinic, and there's a diabetic daycare unit, there's a diabetic foot clinic, so there's absolutely no excuse why you wouldn't be able to see many of these and get really good at this. Okay? And the patients themselves tend to be really knowledgeable about it, and so they can help you out on it. All right, so what time is it here now? Is it time for a break?
Yeah.
Time for a break? What time do we have?
It's 11:40.
11:40, so should we say 11:50? And then get you the motor exam done. Okay, thank you very much, Hamid. He got worked up. He gave me the wrong, we were getting curtains, he gave me the wrong measurement. I sent in the wrong measurement, and then I told him this morning, oh, you gave me the wrong measurement. He got all worked up over it. He's like, well, I said feet and meters. You should have checked both. And I was like being all sheepish. Sorry for being Donna.
Donna, hilarious. Oh my god, I'm not going to be able to communicate with you guys pretty soon. You're all speaking fluent Irish. It is highly embarrassing when a 2-year-old outsmarts you.
I know, but she doesn't. And it's such a thankless job because she constantly answers me. Hi, what's your name? No, only if they say that this person has a diabetic foot and examine that.
Also, you said it's the second part.
Oh yeah, this yeah. So that second exam I was doing there was only if they say this person has diabetes, examine their legs.
Also, you wrote vascular exam. Okay.
Does that make sense to you?
Yeah.
Whereas the other exams what you do if you just say do a sensory exam.
Okay, so they said it was sensory exam that you would get at the beginning. They said, oh, you should take that.
You do the second.
Or your vascular exam. I do that. Like you said.
No problem.
So would it be okay if I left 10 minutes early just so I can make it?
Yeah, you don't actually need to be here. I was just thinking that right now. Sorry. I don't think this out very well in my head.
It is good though for just for next week, so that we kind of I wanted to come as well. Since I'm doing it by myself, I think just for kind of.
Do you know what I found as well? A friend of mine a while back, he's a super nerd, but he found this book online called Mechanisms of Clinical Signs. And I was reading through a bit of it last night. There's one section on it about cerebellar exam, about flocculonodular versus. I'll just forward you the PDF.
That'd be great.
But there's one part there that can give you a little bit of added stuff if you want, just from the regular cerebellar exam.
Ideal. Sorry to bring donuts. Hilarious. How's it getting on with you?
He loves it.
Yeah, that's great.
Hello. Who are you? What's your name? Faris. Okay. Just have to. Oh yeah. That's a good idea, isn't it? Yeah. I don't put them up, but I'll ask them to do that. Okay. Okay. I'm not sure if I'll be able to get the old ones done, but we'll definitely be able to do it from now. Yeah. Okay.
The old videos from previous years. So when you watch the test and you there's like an arrow on the right that you can click into paste. Down about halfway or towards the way down the menu on the right hand side, you'll see Dr. Steve's old videos from previous years. And then it brings you to that kind of answer linked to you because they're all individually linked. It brings you to YouTube. And one of them is called, there's one that's like a channel, and so that has some links to it, and they're going to So how's he getting on? Does he like it?
He loves it. Sorry, I'm sending this thing through to them here.
The new curtain measurement.
Sorry, done that. I know. They're actually really good, these places, because they have this option where you can just go in and modify it.
Where are you ordering?
Blinds to go. Curtains are so expensive. You know,
Yeah.
how much do you think one pair of curtains costs? Like if you get them done, made to measure by
I'd say like a lot.
So we get one pair in our kitchen,
Yeah.
like full length,
Yeah.
700 quid. But these guys are meant to be really good. One of our friends got their entire house done.
We got blinds. So our apartment didn't have any blinds and it just drove me mad. And I was like, well, I've been here for a few years and myself buy blinds for it. They were like $2.5 grand for like 3 blinds.
That's a really quick question. Do you know when you're doing the and you want to test it like dermatome or that you love and stuff?
Yes.
It kind of depends on where.
It does a bit. Yeah.
Should you test kind of the dermatome? Say if you're one day you're like, hey, I'll see if it's like, do you kind of have to go up above to make sure that you're
So what you usually find is that there will be an obvious area that is happening.
yeah,
And so then when you go back and you do the tracking,
yeah,
you pick a sort of a large area of L4. So let's say like from here down, is that normal? What you will be thinking like is, okay, well I think L5 is for sure off somewhere there. So you'll pick quite a large breadth on L5 to do your tracking then to make sure that you've captured it.
okay. I was just wondering, because like, like where you cross it or whatever.
Yeah, no, I know what you're saying, but usually it's not, the abnormality part is not subtle, so therefore the tracking is is usually fairly easy to pinpoint.
Okay, that's right. That's all I wanted to know.
No,
Thanks.
no worries. People keep arranging meetings.
Have the mark sheets been sent off yet?
Apparently, Claire gave them to Prof 3 weeks ago.
Yeah, she's talking to that last week.
That's a student scheme.
So they haven't, yeah, she said she gave them last week, but she didn't know if they could send off. She asked me to finish it, so I have no idea. She won't. But I'll check it. I was just wondering, I was going to check it today. They don't really.
They were meant to be released ages ago, so. I just want them.
Text me any update from the meeting anyway. Okay, like 8 minutes ago. Is that a move kind of message?
Yeah, and you do, yeah, especially when they only send minutes like a few hours before
Yeah, the next
the
one.
next one. It's not that helpful.
Yeah. Not at all.
Plus minutes, like, should have an action place. Like, this person is going to do this, not someone is going to. That really bugs me. Anyway, I better revise my nervers for the different movements. Always
Oh, yeah.
forgetting this stuff.
I sent it to you if you want to look at it. I think I'll screenshot it and send it to you.
Yeah, I have it here.
Oh, perfect.
From 2013.
Okay.
It's great. I have like 900 notes in my phone.
Yeah. I used to, but actually I did a call recently because my phone memory started to seize up and
Mine
it was
is
either
totally
them or
gone.
photos.
Yeah,
so.
yeah, that's the problem.
Yeah.
You know, mine is all photos. Like, you know, Des sends me like this morning. He sends me this, and I should be just like doping and just put like this photo is the same as this photo, which is the same as this photo, which is the same as this one, which is the same as this one. Like,
Oh, what a cute little pajama set.
it's a little top actually. It's a little hoodie.
Your hoodie. So cute. But you're like, save my memory, Dad.
And then I feel really bad like deleting them because it's
Does
like
she love like dolls? Does she like her babies?
she has 2 babas.
Yeah.
We're never allowed to have clothes on.
Okay.
And must be put to bed as follows. Imagine this is the baba.
Yeah.
This is the blanket. Oh, and the baba's facing downwards, and this is the blanket. And if you try and do this, she gets so cross with you. She's like, no! So, I just like wondering where she learned how to suffocate a child so efficiently.
She's prepared.
So, always face down, totally suffocated.
That's so funny. Oh my god. My niece is the same, Alexa. She loves like she always has like she's one Baba that
Has to go everywhere.
missing in the zoo. And
no.
Baba had to be replaced and there was like a mark on her, so we had to like replicate the mark on the new
Oh,
one.
that's just
Like,
quite
kind of a
difficult to
scratch
do.
in the
Yeah,
dog,
yeah,
like,
yeah.
Oh my god, it has to look the same.
Oh, that's.
But she like says, "Where's my own piece?" No interest whatsoever. Dolls, Baba.
And what does she like? What's she into?
Like art, weirdly. She likes like painting, anything to do with that sort of stuff. And then
She's
like
6 now or
imaginary
5?
games, like teddies and stuff. She's 6. Yeah, actually she's 6 next week. So I accidentally bought her the wrong present. So she explained it wrong. Okay, so one thing in a compare, so she's like, I want the Lego Friends of Fair. So I was like, perfect. Went to make her like, there's such a thing as Lego Friends of Fair. I googled it. So I was like, okay. So there was a carnival, and then there was what they call like whale watching, surf and rescue. So I assumed it was a big
one of
tower.
those.
I was like, it's probably the surf and rescue. I mean,
Yeah.
aquarium. You know,
But it's
there's
the
a whale in
carnival.
it.
Oh, that's so annoying.
Anyway, it turned out Hannah was like, will you teach her the name what an aquarium is? We just forgot. And she was like, I know, I'm sorry. And she's like, I'll get the carnival. I was like, no, because the carnival is going to outshadow my aquarium or my lack of aquarium.
That's so funny.
Yeah, yeah. So I just bought the carnival as well because I can't pick it up. Carnival too.
That's so nice. I wouldn't.
She's more interested in like the giant box as well. So,
Yeah,
like,
the boxes are.
flashier the boxes.
Do you think everyone's back?
Yeah.
No. Okay, guys. Sorry, everyone. We're going to get started again. So we're just going to do the motor exam this time, which you've all been doing. Yes, please. Is that okay? Did you get to have any of your coffee? It's okay. You don't mind. You're very good. So tell me what you do in motor exam. Inspection is going to be pretty much the same, and then tone, power, coordination, reflexes, correct? So just a comment again on muscle bulk. Muscle bulk is really prominently decreased in what type of lesions? Lower motor neuron lesions, okay? So if with a lower motor neuron lesion, remember, you're going to have denervation of the muscle, okay? So the actin myosin just totally break down, and it happens relatively quickly. So you can get quite profound muscle wasting quite early on in disease. So that's really useful to you, because when you're looking at the patient, if you see quite predominant muscle wasting, you should be thinking lower motor neuron lesion before you do anything to them. And then fasciculations obviously would be more common in that situation then too, because also lower motor neuron lesion. If you see muscle wasting, but it's only in one area of the body, so for example, proximal muscle wasting, so around the thighs, around the hips, and maybe in the shoulders, what would that make you think? Proximal myopathy, yeah, okay, so you're talking about muscle disease then instead of neurological disease. So muscle bulk is really helpful for you from that point of view as well. What about if you saw it asymmetrically just in one limb? It could be disuse, but if it was quite profound, there's something else that you should be thinking about. So polio can, remember, just hit anterior horn cells in 2 or 3 roots, right? So we have a patient who regularly comes in for exams, and she had polio as a child, and her, I think it's her left leg, is about half the size of her right leg, and she walks with a stick, and her leg itself is actually slightly shortened from it because she got it so young that it affected her bone growth as well, because the muscles were so contracted around it. So you should be thinking still lower motor neuron. So the common thing that you would see is more motor neuron disease to have that profound muscle loss. But then you should be thinking about polio if it's unilateral, okay? And then if, yeah, the common cause of sort of mild loss of muscle on one side is disuse. So that's, you know, someone who has had their leg in a cast for 6 weeks, or it could be that they have some rigidity problem, so it could be like Parkinson's or something like that. But we'll get onto that in more detail next week with, is it next week you're doing that? Next week you're doing that, okay. All right, so inspection is going to be fairly similar to what we just did already, okay? Everyone happy with that? We don't need to go through it again. So then we're now going to talk about tone, power, coordination, and reflexes. So tone, what is tone? The resistance to passive movement. Okay, so you could easily be asked that as you're examining, so you do need to know the definition of that, okay? So what's the different types of tone then that you can have? So normal tone, hypotonia, hypertonicity, and then hypertonicity is divided into spastic, rigid, and parotonia, yeah? So hypotonia, the person, it tends to be floppy. Normal tone is self-explanatory. Then parotonia is what looks like increased tone, but which is totally diminished once the patient is distracted, okay? So can you think of any patients where you've seen that, where they felt like they were quite rigid, and then if they were asked to do something or asked a question, it loosened out as you examined them? Yeah, anxiety can definitely cause it, but demented patients is the common one that we would see in a general hospital like this, okay? So always something to think about. In an older patient who you can't really see that there's a specific neurological lesion, but they feel quite resistant to movement when you're testing them for tone, always consider that and then ask them a question. My question that I ask everyone who's older is, do you have grandchildren and what are all their names? Because it really takes quite a bit of concentration to answer that one. If they're young, I have absolutely nothing. I never leave my house, so I've got absolutely nothing to talk about to them. You guys, I'm sure, can come up with better things than I do, unless you want to know all the character names in Thomas the Tank Engine, in which case I will nail it. So that's parotonia. Then let's talk about the two that you'll actually see with neurological abnormalities. So rigidity and spasticity. So spasticity is your stroke patient, right? So what you will see is that they have increased resistance to passive movement that is velocity and position dependent. Okay? So, Faisal, do you still have that other mic? Oh no, it's here. Great. Sorry, guys. My entire life is going to be bloopers of microphones, I feel. So if we're just taking the arm, so usually what you're trying to do is move 2 planes, 2 joints at the same time, okay? Because that way you'll get a better sense of the tone. And you want it to be a really non-rhythmic, unpredictable movement, okay? So you're doing something like this. And what you'll find then, I'm going to try and get you to try to be a bit rigid there, or try to be a bit resistant there, okay? So with someone who has a stroke, you'll find that they're a bit resistant like this, and then you move to a certain place, and then they actually become much less resistant, okay? So it's velocity dependent and position dependent. Once you get to a certain position, and once you move it to a certain rate, you're actually able to overcome the level of resistance. That's spasticity. With rigidity, it's a constant level of resistance irrespective of the position and the velocity, okay? And the thing that you hear about with that is the cogwheel rigidity of Parkinson's, whereas, so with that, you will have the same level of increased resistance the entire time, and the cogwheeling part comes from the fact that they have rigidity in association with the tremor. Yeah, exactly. So it feels like you're moving around on a cog, and it just cannot be overcome, okay? So the commoner one that you're going to see is spasticity. All right? Rigidity is more with extrapyramidal lesions. And just to show you again how to do that, so usually you're trying to move 2 different planes, 2 different joints, non-rhythmic and unpredictable. When people do this, it's really difficult to assess if someone actually has much resistance or not. So I tend to be a lot more rigorous around doing this. And so you can see, very easy to actually move his arm in completely different ways and different speeds. That's what you should feel for normal, okay? And then that arm feels almost like Play-Doh. All my references will be for 2-year-olds, I'm sorry. If it's hypotonic, okay? Which is less easy to pick up, and so if you don't pick it up, don't worry about it, because they'll have other lower motor neuron findings that are way more obvious, okay? So that's what we're talking about with tone. For power then, what's the scale that we use to measure it? 0 is no movement. 1 is a flicker. 2 is that they can withstand resistance once gravity is excluded. And then 3 is can move against gravity. 4 is move against gravity and some resistance. And 5 is can move against normal resistance or normal power. This is a bit more difficult in the legs than it is in the arms, because let's think about this from a practical point of view. So let's say we want to test hip flexion, okay? So how do I normally test someone's hip flexion? I ask them to lift their straight leg up, and I push down against it, correct? Yeah? So he lifts his straight leg up. As soon as he has lifted his leg up there, before I ever touch it, has he moved his leg against gravity? Yes. Okay. So, is he 0? No. Is he 1? Is he 2? No. He's 3. Yeah? So it's 3 starting off, correct? And then, if I put my hand against it and see, so keep the leg up, don't let me push down, and so I'm able to push a bit because I'm so super strong. So then that's going to be 4. And if he's able to hold the leg up completely, when I say don't push down, it's 5. Your difficulty is when they can't lift their leg up at all, right? Because if he can't lift his leg up at all, how are you going to test whether he can move against gravity or not? So you can slide his leg, can't you? But now are you testing hip flexion anymore? Now you're testing abduction. So you can't test specific movements to the level that you want in the legs. So what's easier to do then is to report the movements separately to the power. So is he able to flex or not? And then report the power for, say, the upper muscle group of the leg. So I'll explain that in a bit more detail now. So let's do your hip flexion again. So can you keep this leg straight, lift it off the bed, okay? And don't let me push down, okay? And now do the same with this leg. Don't let me push down. Right, okay, so that's hip flexion. And what nerve roots are we talking about there? Yeah, 1, 2, 3, depends. Different people have slightly different, but once you're getting ballpark the right area, that's good, okay? So then you put your hands underneath and say push down as hard as you can and don't let me pull your legs up. And we're testing hip extension, and that is L4, L5, S1. Yeah, okay. Then we're going to do hip abduction and adduction. So depending on how big you are and how big your patient is, you can do them one at a time or both at a time. So can you push, keeping this leg straight, push it out against my hand, don't let me push in. So we're testing abduction there, okay? And what nerve roots are we talking about there? Is it nearer to L1, 2, 3 or nearer to L3, 4, 5? Yeah, down L5, S1, yeah, okay. And then testing adduction, don't let me push in, push it in, okay. L4, L5, sometimes S1. Now, then we're moving on to the knees, okay. So this is the part where it's important that you isolate the muscles, okay. So can you bend the knees up for me? Now, what you need to do here, the important part, is that you put this hand here, okay. Why is that? You don't want him to be using his hip flexors, extensors to help him do this, okay. You want to be testing just this, the knee itself, okay. So I'm going to get you, so we're going to do this one first, which is pulling the knee in is knee flexion, and that is testing. No, yes, yeah, sorry, which nerve roots? So kicking out is L3, L4, and then L5, S1. Yeah, good. Okay, so push against my hand, okay, and don't let me pull up, okay? So 2 things I always do for everything else besides these specific ones is hand here, and the only instruction I ever give is push against my hand, okay? Because then you don't have to remember loads of different stuff. And then we do this side, so push against my hand, good, okay. And then we're going to do the opposite, so I'm going to get you to try and straighten that leg, push against my hand, okay. And this one, push against my hand. And we're happy that he is 5 in both of those there, yeah? Okay, and then when we move down to the foot, we're going to do the same thing. We're going to isolate. So we hold here so he can't use the rest of his leg to do the movement for him. So, and then I'm going to get you to push against my hand. So that is what movement? Yeah, and then you can do them both like this, or you can move straight across, push against my hand, push against my hand. And what nerve roots are we talking about there? L5, 5, S1, yeah. L5 mainly for this one, S1 mainly for this one, but you can have contribution to each for both. Okay, and then you can do inversion, push against my hand, push against my hand, and eversion, S1, S2. Okay, so the principles there that I want you to follow are isolating the muscle group and have a simple instruction. You don't have to use what I do, but trying to explain it in longhand can be quite confusing for the patient and takes up a lot of time. So then you want to look for patterns of weakness as opposed to being able to say definitively, okay, the hip flexors were 0 out of 5, but the hip abductors were 2 out of 5. Do you know what I mean? So we're looking for patterns of weakness. So what is the commonest reason that you are going to be doing a lower motor neuron exam, or a lower limb motor exam? A lower limb motor exam is going to be stroke, and you're talking about an upper motor neuron lesion, aren't you? And so therefore you'll probably have unilateral findings, and you will have a definite pattern of flexor and extensor weakness. So can you remember what the pattern is? If I say to you that the classic posture of a stroke patient, if you're playing a stroke patient in a movie and you want to win an Oscar for it, what are you going to look like? You're going to look like this, aren't you? Because that's the classic thing. So in the arm, there's going to be fixed flexion. And why is that? Because after a stroke, which of the muscles are affected more? Extensors in the arm. And then the leg is going to be held like this in extension. And they do this walk like this, don't they, in an arc. Okay? Because after a stroke in the leg, you are going to expect that the extensors are stronger and the flexors are more affected. Okay? So the pattern that you would be expecting to see is that there is going to be poorer power or lower power or more weakness in the legs, in the flexors versus the extensors. That's one of the patterns that you are looking for. Okay? Then, let's say this was a specific nerve root problem. So let's say we had a peroneal nerve palsy, or let's see, common peroneal nerve. That's the commonest one you're going to see in the foot. So then we would be expecting to see weakness only in the muscles supplied by the common peroneal nerve. So we would be expecting the weakness to be mainly below the knee for the most part. Okay? So what I'm saying to you is, yes, grade power and try to grade it as accurately as possibly, but be aware that there are some limitations in how you can interpret that based on the scale that we use about using excluding gravity, etc. And just report it back as patterns of weakness rather than trying to do it specifically for each muscle group. You can do it specifically for each muscle group in the arms to a much easier extent, but for the legs, you need to be aware that there's that confounder there. Okay? So then we're going to talk about coordination. So coordination in the lower limbs, the heel-shin test is the most common thing we do, correct? And coordination abnormalities, you have to think about the fact that if someone has significant weakness, can you really test them properly for coordination? Let's say Faisal was unable to lift his leg up for me, and I try and do a heel-shin test on him. Is that interpretable? How do I know if the fact that he's really wobbly doing it is because this leg is weak or he has poor coordination in this leg? You don't. So if you have had significant weakness in either limb, it is perfectly fine and actually preferential to say, I will not test coordination in that limb because it will be uninterpretable due to the weakness. Okay? Otherwise, you're going to overcall it, and you'll get yourself into this situation where you're saying, okay, this person has increased tone in the right leg, and they've got decreased power in this leg, and they also are hyperreflexic in this leg. But I also noticed that they have poor coordination. So they have everything going for an upper motor neuron lesion of their left hemisphere, but now they have coordination abnormalities as well, so I think that they have a cerebellar lesion too, and you're after making up a second lesion just because you tested coordination inappropriately in someone who was too weak to actually have an interpretable finding. Do you see what I mean? So, but in someone who would say has reasonable power in their leg, you can do the heel-shin test. So, Faisal, I'm going to ask you to lift this leg in the air, straight up. Okay, touch your base of your foot here. Now, bring it all the way down your leg, up in the air again, and then touch here again. And you see, I'm not using many words, I'm just telling him what to do because I'm less likely to mix things up and say things inaccurately if I just show him. Perfect. Now, can you stop that and do it with the other leg over here? So, discoordination, the commonest abnormalities are usually cerebellar lesions, aren't they? There can be sensory ataxias as well, but we'll talk about that in more detail, thank you, when we do gait examination. So, with a cerebellar lesion, it's more likely to occur if it's a hemispherical lesion. Okay? If someone has a central cerebellar lesion, it's usually their flocculonodular area and their vermis that are affected. And they actually have very little to do with the coordination in the lower limbs. So what you will find then is that this test could be normal, okay? So if you have a patient who has dysdiadochokinesia and nystagmus and dysmetria, and it's all on their right-hand side, you will expect, and as she points to the left side, if it's all on their right-hand side, you will then expect them also to have an abnormal heel-shin test on their right-hand side, okay? Because they have an unilateral right-sided lesion because all the findings are ipsilateral to the lesion, okay? If Hamid had a central cerebellar lesion, okay, so that's usually a tumour or something like that, he may have absolutely none of those findings, okay? The main finding that he will have is truncal ataxia. So when he goes to walk, he falls up and down, and his stepping becomes really considered. He can get this high stepping gait, a broad-based gait. He can be very slow on it, and he will fail a heel to shin test walking, yeah? But he may have next to none of the other cerebellar findings that you are used to hearing about, like nystagmus, dysmetria, pass pointing, etc., etc. Okay? So when you put all of that information together, what I'm saying to you is, if you're asked to do a motor exam of the lower limbs, it would be highly unusual for you to have an abnormal coordination part to it, because we know that the abnormal coordination is associated with truncal ataxia, in which case we would have asked you to do a gait exam so you could see those findings. And we know that the other findings that you do get in motor exam, like either hypo or hypertonia, hypo or hyperreflexia, and weakness, are associated with upper motor neuron lesion and lower motor neuron lesions, which don't usually have a coordination element to them. Does that make sense to you? So, while tone power coordination reflexes is how many of you will have learned it, some of you will have learned it as tone power reflexes coordination, because neurologists often prefer to do it that way because they know that TPR abnormalities go together and coordination is a little bit outside of that. So if it were me doing it in the exam now, that's how I would do it, TPR C, because C is least likely to find you an abnormality when you are doing a lower motor neuron, lower limb motor exam. I keep saying that wrongly and I'm going to mix someone up. Is everyone okay with that? So then we move on to everyone's favourite, reflexes. Just some tips around reflexes are the same tips around ABG. Wait until you're ready to do it before you actually do it, because remember there's a reflex arc. So if you actually do hit the tendon here and you get it but you don't see it, what's the natural impulse to do as a medical student? Keep whacking it desperately, right? But the problem is, if you did actually get it, there's a 30-second delay because on that reflex arc as it hits up to your brain, as that the message goes from your spine up to your brain to register that it happened, where you're not going to be able to do it again. Okay, it won't be elicited again. So you have to be okay with the idea that you have to wait a bit of time afterwards, okay? The second thing is just, you know, an awful lot of you will not get the reflexes in the exam, and that won't just be the fact that you're a little bit hypertonic and reflexic on the day, but it'll also be because the patients, no matter how many times you tell them to relax, they just don't do this very well for you. I often would put a pillow in under the patient, particularly if you're quite a small person and they have a big leg. You know, you're not going to be able to hold it for any length of time while you actually try to find this as well. But what you want is to have it only at about a 20, 30 degree angle there. I see people doing this. You're definitely not going to get it. It's not going to happen. Okay? So about here, and again, my tactic is always to ask the patient a question to try and relax them. I think the Gendrasic maneuver is pretty useless. If you want to do it, go for it. Some of you might find it particularly helpful, but I think trying to distract the patient is an awful lot better. So Hamid, how many grandchildren do you have? Sorry? 16? Yeah, can you tell me all their names? Meanwhile, I'm looking for the nice pulpy bit of his, what? Popliteal tendon. Yeah, exactly. So I'm pretty sure that that's where it is now. Okay, so tell me, so what's the oldest one's name?
I can't remember them. There are too many.
There are too many. Okay, just give me a good... are there many boys and many girls?
15 or
15 boys
yeah. And one girl.
and one girl. Okay. And is that the ratio that you like?
No.
No. Okay, so finally I got it there. When he finally relaxed for me. And so what am I testing here? Oh, sorry, what am I testing? I'm testing his reflex, okay? But specifically, which nerve roots are going to be involved? L3, L4. And what is it that I'm looking for? Is it that his leg kicks out, for example? No. What's the thing that you're looking for is? Contraction of the quads. Okay. So theoretically, you should have your patient have their quads exposed so that you can see the contraction. Okay. So tell me the boys' names again. Tell me instead, what football team do you support and why? None. That's not. You're not allowed to come to Ireland from a Middle Eastern country and not have a team that you support. It's not allowed. Do you like racing then? Car racing? What's it called? Yes. Grand Prix. Yeah. You like Grand Prix? Okay. Who do you like in that? Hamilton. Even with his hair. Yeah, I heard he's the best. I saw he was on Graham Norton the other day and he was saying he's the second oldest or something like that. He seems to be pretty confident in himself. I don't like him. So why do you like him?
I don't know.
Okay, good answer. Great answer. Now, this leg up here. So what are we testing now? Yeah, L5, S1. Okay. Variety of different ways you can do this. This is my preferred way. Usually I have a patient who's a little bit more relaxed than Hamid. So feeling around for the tendon for as long as you can. And that one was actually much better than this one. Great. And then I usually need to move over to do this because I'm pretty useless with my left hand. So that one didn't go so well. Okay, a little bit of one there. Now, you can do my one on my leg now because I have very hyperreflexic knees. So you can see what it should look like. Okay, so let's feel for the tendon here. So just about there, I would say. You can get me back now. You can hit as hard as you want.
Do you have grandchildren?
Do I have grandchildren? I've got... Fair play to you. And do you want to do this one? You can go to this side if it's easier. So I have 14 grandchildren.
No, don't look.
Oh, don't look, sorry. So I have 14 grandchildren. Kim, Kylie. So, see, perfect. Excellent technique. Well done. Then, clonus exam. So, sorry, I should have said there. What if you saw that this was hyperreflexic here, and actually at the same time as the quads moving, you saw that he had an ankle response as well? That's called pathological spreading of reflexes, and you get that in motor neuron disease. So patients who become really hyperreflexic, you see it in the earlier stages of motor neuron disease. So when it's a relatively new diagnosis, usually in the first 2 years. And then as the disease progresses, they tend to get more lower motor neuron findings and they become absent. But I guarantee you, and stroke patients, you can see it too if they've got a really dense stroke. So I guarantee you there's someone here who has seen it happen. You can all see it in the arm, so when you do a biceps reflex, the brachioradialis reflex happens at the same time. So these are just people who have become really hyperreflexic due to the extent of the disease of the upper motor neurons. So it's called pathological spreading of reflexes. And in that person, you're pretty much guaranteed that they will also have a positive clonus test. So when you're testing for clonus, hold that arm here, and then you need to think of another question to ask them about. So if you can tell me all the races that Lewis Hamilton has won in the last 6 months. Yeah, in alphabetical order, please. So I'm holding here, and I'm just moving the foot little by little, and I'm trying to distract him. Come on, you haven't given me a single one yet. And then a very quick movement like that. Everyone see that? No. Okay, so we'll do it again. So come on, tell me at least one. What's the most famous Grand Prix?
What's the again?
Spain, Monaco, France. That's not alphabetical. Oh, you're just telling me, oh, these are all of them, or these are all the ones he's won? Okay, so now stop thinking about what Rohinio is doing and look at what I'm doing, guys. Okay, so it's so you're moving the foot just backwards and forwards, and then a very really quick movement like that. Okay, and what will you see? Flapping, so usually one or two flapping movements there of the foot with the clonus. Okay, and obviously it should only be on the side where the lesion is. And in most of these diseases, on the stroke, most of the time you're going to be talking unilateral, whereas in motor neuron disease, bilateral. If you saw it in one leg and not the other in motor neuron disease, that they still could have motor neuron disease. One side might be worse than the other. Okay, so that's a very straightforward exam that you guys have been doing for forever and a day. Oh, sorry, I only did the tone in his arms, didn't I? I didn't actually show you a technique for doing the tone in his legs because we were just speaking about it there. So, variety of different ways you can do it. Most people just do this. That's fine. It's just not particularly helpful if they have only a mild deficit. So the other thing you do is this. A really fast, vigorous movement at the knee without warning the patient. And what you will see in a patient who is hypertonic is that they can have actual clonic movement when you do that to their foot, so you'll see moving back and forth, and you'll just get a better sense of how much resistance there is. Okay. You asked them beforehand if they're in pain. I knew you weren't because you're so well, but you don't tell them you're going to do it because they'll automatically clench up if you do. Okay. All right. So I would suggest tone, power, reflexes, coordination, and then moving on, but there isn't any requirement to do it in that particular sequence. And again, just be careful of what you're interpreting, particularly with the coordination. And it's upper motor neuron lesion or lower motor neuron lesion. 95% of the time it'll be an upper motor neuron lesion because most patients who have lower motor neuron lesions are quite unwell because motor neuron disease is the commonest cause that we see. But you could have one of our nice polio patients who comes in as well, so don't completely rule it out. Okay, any questions, everybody? So I think next week, I'm not here, unfortunately, but you're doing Parkinson's and cerebellar exam for anyone who wants to prepare in advance. And yes, then we'll see you after that. Thank you again very much to Hamid and to Faisal and to Rohinio for all his Grand Prix knowledge. And we'll see you next week. And someone had the suggestion that we put the names of the tutorials rather than the dates on them, so I'll ask Ray to do that for you so that it's clear to you. Thank you very much again. I hope someone gives you notes each week. Good. Hello. What's your name? Matthew. So what I would say is there was normal power in the extensors of the lower limb, however, there was abnormal power in the flexors, and I would estimate this to be about a 3 out of 5, but I wasn't able to test it against no resistance. Does that make sense to you? Yeah, exactly. And there's other ways of assessing power, but the RMC one, which is the 0 to 5, is the one that's most used. But everyone recognises it's imperfect. It's really just a gross screening as opposed to something you'd, hang your hat on. Okay? Hi, what's your name? Mohammed. Yes. Oh, is it not? I'm not the person to ask about that, Mohammed, Mohammed, because I don't do any of the aftercare. So if you email Ray Lohan, so I think it's Lohan_R, but if you'll find him in the Outlook, he's the person who puts the videos up for us, and he'll let you know. Okay. If you know the date for him, even better. How are you getting on with everything else? Trying to balance everything.